Hi friends, it's Dr. Russ. This video is about plantar fasciitis. Our patient Laura came in with foot pain, and I thought it would be interesting to show you how we deal with this. Like most plantar fascia issues, it involves the calf. A lot of times the issue originates in the calf. So we work through the soleus, the gastroc, the tibialis posterior, free up movement of the fibula, and adjust the midfoot. Hope you enjoy the video. Questions and comments always welcome. And remember, you can support our channel by becoming a member, like, subscribe, and comment, or open an account on our full script dispensary and buy your supplements from there. We get a cut from that. 20% discount for you all the time. Thanks for watching. Hope you enjoy it. We have a plantar fasciitis case today. This is Laura and Enzo, the dog. The pain is at the first metatarsal phalangeal junction, crunchy and stiffness through the great toe, pain straight through right here, right in the plantar fascia, and then tight calves. So when it comes to the lower body and the leg, anytime we're working with really basically anything, we have to look at the knee as well. So even though the symptoms are here, we're going to look at everything from the toes through the sole of the foot, around the heel, including the hindfoot joints, the midfoot joints, all of the muscles in the calf, the gastrocnemius, the soleus, the tibialis posterior, the peroneus, longus, and brevis, and then the deep toe flexors. And then we're going to look at the joints of the knee, the tibiofemoral joint and the proximal tib-fib joint, which is right up here. So let's just start with kind of a general survey. Everything looks intact. There's nothing really jumping out at me as being abnormal. Just feeling muscle tone here. So as I come in with this, one finger on the medial, one finger on the lateral, I'm on the soleus here. I'm deep to the gastroc. The gastroc is here. That's what I'm tapping. And a couple things to remember anytime you're working in the calf. It's very sensitive on everybody, so take it slow. The other thing to remember is that fascia called the crural fascia, that's the deep fascia that envelops the whole thing and keeps it from all just sort of splooshing out with gravity. That crural fascia is really dense and really thick. And as a provider, someone who's doing body work, you can hurt yourself. You can hurt your fingers on someone's lower leg by engaging that crural fascia too quickly because it will push back really, really hard. So again, no swelling, which is good. A little bit of trigger point activity in the soleus. And the heel alignment looks good. So I've got her calcaneus in neutral right there. It's able to invert and evert. Normally inversion is much greater than eversion, as we're seeing here. Where we get a hard stop on eversion because the lateral malleolus sticks down further. Over here on the right leg, there's that lateral malleolus, sorry Laura, and it just sticks down further than the medial and prevents too much eversion of the calcaneus. But we need to have some eversion. Let's look at dorsiflexion. So as I'm dorsiflexing her ankle and lifting her calf, that's a pretty good range of dorsiflexion here. So there's not a lot of restriction in the joint, but she's feeling tension in the calf, which I correlate to the trigger points that I felt in that soleus. So we'll come back to that in a minute. Coming now through the sole of the foot and in the medial arch, feeling those really important muscles. The abductor hallucis right there, the tendon of the tibialis posterior, really deep in there, right there, feels pretty mobile. Just kind of falling off that calcaneal tubercle onto the plantar fascia, and this is where we start to feel some restriction and congestion right there. Right around the level of that second row of tarsal bones. And then coming through and palpating the mobility of all 5 of these metatarsals. Those are the long bones right there. Okay, so what jumps out at me here is that this is a pretty functional foot. There's not a lot going on structurally or biomechanically, but enough to cause symptoms. So let's work through it. First things first, let's get some movement through the plantar fascia right here. This is a good time to remind ourselves that the plantar fascia blends with the calcaneal tubercle and the periosteum of the calcaneus and comes around the calcaneus and blends with the Achilles tendon. So whatever's happening in the gastroc and soleus is happening here as well. A lot of times we can trace plantar fasciitis back up into the deep calf, and I think that's what we're going to see here today. So this is very gentle mobilization of the superficial and deep fascia. Again, I don't want to go real deep, real hard. This is sensitive tissue on people, and I don't want to hurt my hands. But we can just gently mobilize that and rub that like that. And we're going to start to create that continuity and fascial continuity across the calcaneus up and over with these long strokes like this. These are not specific strokes. This is just kind of general movement. And in doing so, I can not only help the circulation in the area and increase her proprioception through her ankle, but also give myself an opportunity to see where am I feeling things really kind of getting hung up. And it's really starting right there. So the nice thing about this calf is that it's pretty easy to see what's what. And we still got Achilles tendon right up here, and then it starts to transition into the muscular tissue right around here. And that's where I'm feeling the restrictions start. It so happens that where the muscle meets the tendon is kind of a weak point in the structure. So we see issues arising at the myotendinous junction pretty frequently. Okay. So we're going to work this section here gently but directly. So starting with her in plantar flexion. So when someone's lying face down prone, they're in a little plantar flexion, which is putting slack into the Achilles tendon, the gastroc, and the soleus, and gives us some nice, easy access through the fascia into those tissues. Nice deep breath here, Laura. And we're going to start to get a little more specific here, and I'm going to start to use a little bit of dorsiflexion to slide the muscle under my finger. So I've got my fingers here right in the center of the muscle. Her foot's in neutral, and as I dorsiflex, it's stretching that Achilles tendon and those calf muscles underneath my finger. And I'm continuing with my superior traction while I give dorsiflexion. So this is very directly elongating the gastrocnemius and the soleus. We're not worried about them being too long. We want to make sure that they're pliable, flexible, and have good circulation through. Do you need a break? Okay, good. And let's do that again. Coming here, starting laterally, and moving medially with each successive stroke. I'd say I'm using pretty moderate pressure here, considering that our patient is very relaxed and breathing well. I think we're doing okay. So that's the gastroc and the soleus. Now, how are we going to get deep to these and palpate, assess, and treat the deep toe flexors, which are way under there? Knowing the crural fascia is really thick and dense, knowing that all the stuff is really sensitive, what we want to do is move slowly. Okay, so here's the medial head of the gastroc and the side of the soleus right there. So I'm just going to kind of lift them and pull them out of the way. You can't do this on everybody. Some people's calves are so tight you just cannot get in there. And so here's her tibia, and I'm actually palpating along the posterior side of that sharp medial border of the tibia. And I'm not using a ton of pressure because I don't need to contact the tissue too directly, but I can feel the mobility deep in the calf of those tissues from out here. And that's what I'm doing. And now the normal texture of these tissues is pretty stringy and grainy. It's like if you had felt this, if you felt that texture in the paraspinals, you would say, oh, these are really tight. But when you feel that ropiness deep in there, that's not tight muscle. They're supposed to be tough. They're supposed to be really ropey and grainy because they're under a lot of stress all the time. Okay, so nothing in there is actually really jumping out at me, and that's good. So we're going to take an approach here on the lateral side. So when we're looking at the lateral calf, kind of the main structure that dominates this whole thing is the fibula. So that lateral malleolus is the distal end of the fibula. And as we come up through the shaft of the fibula, there's the head of it right there. So we have two articulations between the tibia and fibula, the proximal and the distal. And either of these can get restricted and stuck and need mobilization, but it's the proximal one that does more often. So it's pretty easy to palpate. It's right under the skin. And as I dorsiflex her ankle, we want to see a little bit of superior movement of the head of that fibula, which you can right there. So superior, inferior, superior, inferior. And I also need to feel movement of the fibular head as I evert and invert. And hers feels good. It's moving well. So as we come down along the posterior edge of the fibula, one of the first muscles we're going to come into, again, deep to the gastroc soleus, is the tibialis posterior. Such an important muscle for ankle stabilization. It's a really interesting muscle. It's got a central tendon that comes up, and that fibers kind of feather out to either side. And when it contracts, it pulls together the tib and fib and stabilizes the whole lower leg. So we think of it as a plantar flexor and everter, but it's also very much a stabilizer of the whole lower leg. And this is a little bit sticky through here. So as you can see, I am dorsiflexing and everting her ankle while I mobilize that tibialis posterior from the lateral side. I don't want to dig in too deep. It's just going to make her tighten up, and it's just going to hurt my fingers. But we can get nice movement through there. Good. And then finally, we need to look at the peroneals. Some people call these the fibularis muscles. I learned it as peroneus, so that's how I call it. And again, these are plantar flexors everters. So let's dorsiflex invert and see where are they sticky. This is a little bit of an awkward angle for you to see, but let's do this here. Good. That all feels pretty smooth. So this brings me back down to the midfoot. The symptomatic range here through the midfoot, and wanting to get a little more mobility right here. So just as the plantar fascia comes off the calcaneus, that's where it's getting hung up. And there's like the quadratus plantae muscle and the lumbricals in there. They're so tiny and so deep that I'm not going to pretend that I can palpate them out. I can't. Maybe some people can, but I can't. But what I can do is get a little separation. So from the medial here and from the lateral here, I'm getting deep to the plantar fascia. I'm giving it a little pinch and a little lift. And by lift, I mean in this direction toward you. Just like that. So space, creating space for fresh arterial blood, flushing out congested venous blood and lymph. And making sure things are mobile and pliable. So next, I think we can do a manipulation of the midfoot to help loosen this up. So would you turn over? This one is best done with the person supine. And let's get our landmarks. So here's our malleoli. So right in between them is the dome of our talus. Yeah, and as we fold her foot into dorsiflexion, that's where the movement takes place. So talus is here, and as we slide off the talus, on the medial side, we hit the navicular. And then we've got our 3 cuneiforms and our cuboid here. And so what we want to make sure can happen easily and smoothly is dorsiflexion through the dorsal midfoot joints. That's where things tend to get caught up. And it feels good here on the lateral aspect. But as we come more medial, that's really sticky and stuck right here. So first cuneiform, first metatarsal right here. So this adjustment will be a pull of the cuneiform toward me with my pointer, or maybe my middle finger if that feels like a better grip, while I dorsiflex the forefoot over that. Take a nice deep breath here and let it out. And it's a pull toward me. Okay, my hands are a little slippery, so I'm gonna do this. So this is my little hack. I do it through the sheet. Nice deep breath and let it out. Good, good. Yeah. You okay? Yep. So looking now at that dorsiflexion, and there's more mobility through the midfoot than there was before, which is good. That's what we want. So that was some work through the plantar tissues, through the layers of the calf, the tibialis posterior and the peroneals, and then an adjustment to the midfoot. And we're just going to finish this up with some gentle work through the metatarsals, those interosseous muscles. This muscle here, the extensor digitorum brevis. Laura, can you pull your toes up? You see it pop up right there. Let that rest. That's a kind of a hidden gem of a muscle, especially in inversion sprains. It'll get strained, and it's often neglected in rehabilitation, both in terms of exercise and manual therapy. So that's one you want to make sure you're working if you've got someone with an inversion sprain. Okay, that's our session. Thank you, Laura. Thanks, Enzo.